Bismillahirrahmanirrahim. I am Professor Dr. Sarfraz Hussain Sayed, Head of I Unit 2, Punjab Medical College, Faistabad Medical University, Faistabad. We are going to discuss today about the orbital tumors. The orbital tumors have been classified into primary tumors of the orbit, the metastatic tumors, and the orbital invasions from the adjacent structures. The primary tumors are vascular tumors, lymphomas, rhabdomyosarcoma, neural tumors, and lacrimal gland tumors. The most common orbital tumors in children are dermoid cyst, capillary hemangioma, lymphangioma, rhabdomyosarcoma. In adults, the more common are lymphoid tumors, orbital varices, cavernous hemangioma, and meningioma. The orbital varices are combined venous lymphatic malformations of the orbit, and they consist of thin-walled, distensible, low-flow vein-like vessels. They are probably hamartomatous, which are a disorganized overgrowth of mature tissues normally present in the involved area. They present in most cases as unilateral, and the most frequent site is upper nasal quadrant of the orbit. The lesions of the lids may be associated with intermittent non-pulsatile proptosis without a bruit. The proptosis is precipitated by coughing, straining, or Valsalva maneuver dependent head posture and jugular vein compression. The investigations are the imaging by MRI, MRV, and CT scan, ultrasound, and venography. These show a lobulated mass with variable contrast enhancement and may demonstrate phleboliths. There may also be orbital expansion and orbital wall defect seen on the imaging of the orbits. The complications are the hemorrhage in the varices may cause painful proptosis. There may be thrombosis, optic nerve compression, in ophthalmos in long-standing cases. The treatment is either observation or intervention. In small lesions, the observation is enough, sometimes the involute. The indications for intervention are the complications, which is hemorrhage and causing painful proptosis, thrombosis, optic nerve compression, and enophthalmos. The excision is difficult and may be complicated by hemorrhage and optic nerve compression. Specialized techniques may be used like embolization and carbon dioxide laser therapy to the superficial lesions. The capillary hemangioma is the most common tumor in childhood. It may present as small isolated lesion of the minimal clinical significance or a large disfiguring mass that can cause visual impairment and systemic complications. It consists of anastomosing small vascular channels without true encapsulation, principally because of proliferation of the endothelial cells. Systemic manifestations include thrombocytopenia, that is also called Kesa-Batch-Marett syndrome, and high output cardiac failure. We may see the Faces syndrome in these cases. This is an eponym of different abnormalities, the eye and elsewhere. The P stands for the posterior foci malformations, most commonly the Dandy-Walker variants. There may be hemangiomas elsewhere, particularly large segmental facial lesions. There may be arterial abnormalities like cerebrovascular and in the carotid system. Cardiac abnormalities may be coarctation, aortic arch abnormalities, and ventricular septal defects. Eye abnormalities may be microphthalmos, retinal vascular abnormalities, persistent fetal retinal vessels, optic nerve atrophy, iris hypertrophy, colobomas, excavated optic disc. The sternal cleft, supraumbilical raphe, or both may also be seen in these syndromic children. The diagnosis: the patient is brought by the parents who notice a discoloration or red or bluish mass over the lids, face, or elsewhere over the body, usually in the first few months of life. We should always rule out the orbital involvement. The superficial cutaneous lesions appear as bright red in color, called strawberry nevi. When involves lid can cause occlusion amblyopia. Deeper lesions appear blue or purple through the skin. A large tumor may change color to deep blue during crying or straining. Pulsation and bruit are typically absent. Deep orbital tumors give rise to unilateral proptosis or dystopia without a skin discoloration. Here you can see this is a capillary hemangioma superficially involving the lid and causing the ptosis and occlusion of the visual axis. Here, and it appears red, bright red, that is strawberry nevus. The same is here, it is small of the lower lid and not causing any amblyopia because of the occlusion of visual axis. Here it is bluish and more deeply involving the orbit and causing the upward displacement of the globe as well. Here again you can see this one, a strawberry nevus as well. The investigations are imaging, obviously. The ultrasound or B scan of the orbit shows medium internal reflectivity. Here you can see that medium internal reflectivity. On MRI and CT, lesion appear as soft tissue in the anterior orbit. Or as an extraconal mass with finger-like extensions. Maybe orbital expansion but no bony erosion. It initially is a small, appearing in the first few months of the age, and then usually it appears in the first year and then it gradually increases in size. And then it uh, spontaneously involutes. Here you can see the progression. The same child during early childhood, you can see there and then it has increased in size and also is causing a dystopia in this child as well. The treatment is observation because they grow at the age of 3 to 6 months and then begin to resolve. One third resolve by 3 years and others in 7 years of age. The indications for treatment are when they are causing amblyopia due to the astigmatism or anisometropia, occlusion, or strabismus. Less commonly, the cosmesis, optic nerve compression, or exposure keratopathy may need to be treated. The life-threatening lesions should also be treated. The treatment modalities are beta blockers with oral propranolol are the first line of drugs currently. The local injection of steroids like triamcinolone acetonide, the topical steroids like clobetasone, propionate cream, and systemic steroids for large lesions. The lasers can be used for superficial lesions with 2 mm of depth. The interferon alpha 2A and vincristine are given systemically when the steroid resistant cases appear or when there is site or life threatening lesions. Local resection with cutting, cautery, or carbon dioxide laser can also be employed. Lymphangioma is a rare hematomatous vascular tumor that tends to enlarge and infiltrate diffusely with time. Some authorities believe lymphangiomas to be a variant of the venous orbital anomalies, varices, across a single spectrum, and the term combined venous lymphatic malformations of the orbit has been suggested. Although usually isolated from main circulation, bleeding into the lumen may occur with subsequent formation of blood-filled chocolate cysts that may regress spontaneously with time. It presents usually during the early childhood and it must be differentiated principally from the orbital venous abnormalities and hemangiomas. Intracranial vascular malformations can be present in association with the ocular lesions. The diagnosis can be clinically. The anterior lesions appear as bluish masses in the upper nasal quadrant. The posterior lesions present as slowly progressing proptosis. The rapid, progressive, painful proptosis with optic nerve compression and conjunctival chemosis may occur when there is a bleeding inside the lymphangiomatous lesion. The lesions may occur in the lids, conjunctiva, and oropharynx. Intracranial lesions may also be present. Now you can see there, this is an orbital lymphangioma. It can cause a dystopia. Here there is a rapid progression to a painful proptosis with conjunctival chemosis and hemorrhage. And here you can see this one. This is a lymphangioma metis on CT scan. Lymphangioma causing a in which there is a hemorrhage and which is causing a proptosis. You can see the conjunctival involvement in lymphangiomatous lesions. Here in the soft palate, you can also see these lesions of lymphangiomas. The treatment in many cases when the visual prognosis is good with there is no treatment required, we can the surgical excision is difficult because the lesions are unencapsulated, friable, bleed easily, and commonly infiltrate the normal orbital tissues. Repeated subtotal excision may be necessary sometimes. Persistent side-threatening chocolate cysts can be drained or removed subtotally. Carbon dioxide laser with controlled vaporization can also be employed. Cavernous hemangioma is the most common orbital tumor in adults. May occur anywhere but more frequently occurs within the lateral part of the muscle cone just behind the globe and behaves like low flow arteriovenous malformation. It is more common in the females than the male. Histologically, it shows endothelial lined vascular channels of varying size separated by the fibrous septa. Presents at slow progressive axial proptosis, usually unilateral, optic disc edema, and choroidal folds. It may appear as lesions at the apex, may cause gaze evoked transient blurring of the vision due to the optic nerve compression, and it may present as impairment of the extraocular movement excursion. Here you can see these are blood-filled spaces separated with the fibrous septa here, and here you can see this one as a proptosis, the axial proptosis. On CT scan you can see an intraconal well circumscribed tumor or space occupying lesion in the orbit. Here the lymphangioma has been excised through the orbitotomy. Investigations are CT scan and MRI to show the well circumscribed orbital lesion, usually within the muscle cone. The treatment is as it is well encapsulated, hence surgical excision by orbitotomy can be performed easily. Lymphoma of the ocular adnexa constitutes 8% of all the extranodal lymphomas. Orbital lymphomas are B cell variety, which is non-Hodgkin lymphoma. It may be primary or secondary. It presents in the middle to old age as orbital swelling progressing to proptosis. Any part of the orbit may be affected. Anterior lesions can be palpated with rubbery consistency. Sometimes only conjunctiva and lacrimal gland is involved most frequently. Local lymph nodes must be palpated. Systemic examination by specialist must be performed. Now here you can see this one. There is this one, and then here you can see after you have everted the upper lid, and on imaging you can also see this one here, the lesion which is causing proptosis and forward displacement like a homogeneous lesion, space occupying lesion in the orbit. The MRI is usually important. The biopsy has to be performed to establish the diagnosis. Systemic investigations need to establish the extent of the disease. The treatment radiotherapy is used for localized lesions. Chemotherapy is recommended for the disseminated disease. Immunotherapy such as rituximab and surgical resection in a well-defined lesions may be important. Rhabdomyosarcoma, the most common primary malignant tumor of the orbit in children and most common sarcoma in the children. Highly malignant tumor, average age of presentation is 7 years up to 16 years. It is derived from undifferentiated mesenchymal cells that have potential to differentiate into striated muscles. Various genetic predispositions are identified, including the RB1 gene, which is a retinoblastoma gene. Histological classifications are there are four types: embryonal, which is has the best prognosis and has the best differentiation to the skeletal muscles, and it is the fortunately the most common as well. The alveolar has poor differentiation with worse prognosis. Botryoid and pleomorphic are rare in the orbit with a better prognosis. The diagnosis may be the clinical, in which there is rapidly progressive unilateral proptosis, which may mimic the inflammatory orbital cellulitis. Usually presents as a supranasal or superior swelling. There may be associated swelling and redness of the overlying skin. The diplopia is frequent, but pain is a less common feature. And the overlying skin is usually not warm. You can see there is a superior swelling of the orbit, which is causing proptosis, as well as the redness and discoloration of the upper lid, mimicking the orbital cellulitis. Again, here you can see this one with the swelling, and this how it appears as unencapsulated lesion causing proptosis on MRI. On CT scan, you can also see the lesion, which is also involving the cranial cavity as well as the temporal fossa. For investigations, MRI shows a poorly defined mass, CT shows a poorly defined mass of homogeneous density, often with adjacent bony destruction. Incisional biopsy is performed to confirm the diagnosis and establish the histopathological subtype and cytogenetic characteristics. Systemic investigations are for the metastasis. The most common sites are lung and bone. The treatment involves combination of radiotherapy and chemotherapy and sometimes surgical debulking. The prognosis of orbital tumor is good. Lacrimal gland tumors are two types, the benign and the malignant. The most common benign are the pleomorphic lacrimal gland adenoma. The pleomorphic adenoma is the most common epithelial tumor of the lacrimal gland and is derived from the ducts and secretory elements including myoepithelial cells. On histopathology, the inner layer of the cells forms glandular tissue that may be associated with squamous differentiation and keratin production. The outer cells undergo metaplastic change, leading to the formation of myxoid tissue. Young to middle-aged adults are the predominantly affected group. Symptoms: it is a slowly progressive proptosis that may be for years. The palpebral lobe tumor causes lid swelling and visible after the lid eversion. Orbital lobe tumor causes infranasal dystopia, proptosis, ophthalmoplegia, and choroidal folds. The investigations are on CT scan, round or oval mass in the lacrimal gland fossa with indentation of the globe, and bone may contain calcification but no bone destruction. The treatment is axion in toto, either transseptal or lateral orbitotomy. You can see here you can see this is keratin in the lobules of the um, tumor, and here you can see the swelling of the lid and also mild proptosis. We can see when we invert the lid, we can see a swelling of the lacrimal gland in the supratemporal part of the orbit. Here it is a CT scan, axial uh, coronal section, in which we can see uh, a space occupying lesion superiorly in the fossa for the lacrimal gland. The lacrimal gland carcinoma is rare but carrying morbidity and mortality. It affects the middle aged individuals. The histological types are adenoid cystic type, which is 50%, pleomorphic adenocarcinoma, mucoepidermoid squamous cell carcinoma. Histopathology shows nests of basaloid cells with numerous mitoses. It presents in previously excised benign tumor, which recurs with more rapid growth, with sometimes malignant transformation, or a long-standing lid swelling starts to rapidly increase in the size, or a swelling of the rapidly increasing size without a previous abnormality, rapidly growing swelling in the lid or globe with the displacement. The pain may occur if inflammation is associated. Looking at the patient, the swelling in the lacrimal sac area may be seen. There is an infranasal dystopia. There may be signs of orbital congestion such as epibulbar congestion, proptosis, periorbital edema, and ophthalmoplegia with involvement of the orbital apex. Hypoesthesia in the region supplied by the lacrimal nerve, optic disc swelling and choroidal folds. CT scan shows a globular lesion with irregular serrated edges, often with contiguous erosion or invasion of the bone. Calcification is commonly seen within the tumor. Here you can see this one. There is a swelling in the supratemporal area causing a dystopia, downward displacement, and swelling around the orbit, swelling of the lids. And here you can see this is a tumor on CT scan with coronal section. You can see the swelling in the lacrimal area, which is also causing the destruction of the bone. The treatment involves excision of the tumor and adjacent tissues. Extensive tumors may require orbital exenteration or midfacial resection, but the prognosis for life is frequently poor. Radiotherapy combined with local resection may prolong life and reduce pain. Adjuvant intra-arterial chemotherapy and or brachytherapy may be utilized in some cases. Cystic lesions, there may be dacryops. It is a frequently bilateral cyst of the lacrimal gland that is thought to develop from a dilated, obstructed duct. A round cystic lesion protrudes into the superior fornix from the palpebral lobe of the gland and may present with inflammation. The possibility of a malignant tumor should always be considered. The treatment involves excision or marsupialization with the histopathological analysis. Dermoid cyst is an orbital dermoid cyst is a choristoma, which is a mass of histologically normal tissue in an abnormal location, derived from the displacement of ectoderm to a subcutaneous location along the embryonic lines of closure. The dermoids are lined by the keratinized stratified squamous epithelium, like the skin, have a fibrous wall and contains dermal appendages such as sweat glands, sebaceous glands, and hair follicles. Epidermoid cysts do not contain adnexal structures. The dermoids may be superficial or deep, located anterior or posterior to the orbital septum, respectively. Epibulbar dermoids and dermolipomas are related lesions. Dermoid cysts are one of the most frequent encountered orbital tumors in the children. You can see in child, this is a dermoid cyst, and in adults, you can see an orbital dermoid, which is also causing dystopia of the globe. The investigations are imaging. In superficial imaging shows a well circumscribed heterogeneous cystic lesion. Here you can see this one here on the temporal side of the upper lid. The deep lesions, the imaging again shows a well circumscribed lesion. Some deep dermoid associated with bony defects may extend into the infratemporal fossa or intracranially. So this is a circumscribed cyst in the orbit. On orbitotomy, we can see this one as a cyst here. The treatment of dermoid cyst, it may be conservatively treated when the lesions are small, bearing in mind the possibility of rupture, particularly from trauma. The inflammation can be addressed with oral steroids. Superficial dermoid, the treatment is by excision in toto, taking care not to rupture the lesion, since leaking of the keratin into the surrounding tissue typically results in severe granulomatous inflammation. In case of deep dermoid, the excision in toto is advisable because deep dermoids enlarge and may leak into adjacent tissues, inducing inflammation, often followed by the fibrosis. If incompletely excised, dermoids may recur with persistent low-grade inflammation. The sinus mucocele sometimes, especially the ethmoid, may invade the orbit and may cause proptosis. This occurs when normal drainage of the secretions of paranasal sinuses is obstructed. Most commonly, invasion of the orbit occurs by mucocele from the sphenoid and ethmoid sinuses, rarely from the maxillary sinuses. The clinical features are the orbital invasion presents as proptosis, dystopia, diplopia, or epiphora. Pain may occur when infected mucocele or mucopyoceal is there. CT scan shows as soft tissue mass. The complete excision is the treatment of, of choice. Neural tumors are optic nerve glioma. It is a slow-growing pilocytic astrocytoma that typically affects children. The median age is 6.5 years. Histopathologically, it shows spindle-shaped pilocytic hair-like astrocytes and glial filaments. Prognosis is variable. Some have an indolent course with little growth, while the others may extend intracranially and threaten life. Approximately 30% of the patients have associated neurofibromatosis type 1, and in these patients, the prognosis is generally superior. Malignant glioma or glioblastoma is rare, has a very poor prognosis and usually occurs in adult males. The diagnosis is clinically slow progressive visual loss followed by proptosis. It may be reversed in a sequence. Acute loss of vision due to the hemorrhage into the tumor. The signs are proptosis is often non-axial with temporal or inferior dystopia. Optic disc edema later may result into atrophy, opticociliary collaterals, central retinal vein occlusion, occasionally intracranial spread to the chiasm and hypothalamus may develop. Here you can see an intraconal optic nerve glioma in which you can see the proptosis usually is axial, and these are the pilocytic cells which you can see with the thread-like cells there. And this is a CT scan of a patient causing a pushing, causing the choroidal folds there, and there is a spindle-shaped tumor in the cone of the orbit muscles. The MRI effectively demonstrates the tumor and intracranial extension if present. CT scan shows a fusiform enlargement of optic nerve with a clear-cut margin produced by the intact dural sheath. In patients without neurofibromatosis 1, the nerve is more irregular and shows low-density areas. The treatment is observation as the tumor is intrinsic to the optic nerve. Resection means that all the vision will be lost in operated eye. Indications for treatment is the typical pilocytic astrocytoma on imaging in whom the tumor is confined to the orbit. If there is good vision, no significant cosmetic impairment, serial MRI is important if this option is chosen. Spontaneous regression has been reported, usually in neurofibromatosis 1, but is very rare. The surgical excision with preservation of the globe. The indications is large or growing tumors where complete resection of the tumor can be achieved. If the vision is poor and prognosis is significant, a key goal is to prevent chiasmal involvement, and an intracranial approach may be necessary to achieve adequate resection. Radiotherapy may be combined with chemotherapy for tumors with extension that precludes complete surgical excision. Optic nerve sheath meningioma. The optic nerve sheath meningioma is a benign tumor arising from the meningoepithelial cells of the arachnoid villi surrounding the intraorbital or less commonly the intracanalicular portion of the optic nerve. In some cases, the tumor merely encircles the optic nerve, whilst in others it invades the nerve growing along the fibrovascular pile septa. Two-thirds of all the meningiomas affecting the optic nerve arise from the extension of the primarily intracranial lesions. Primary optic nerve sheath meningioma are less common than optic nerve gliomas. It affects the middle-aged women. Histopathologically, there are two types: meningoepithelial meningioma. It contains irregular lobules of meningoepithelial cells separated by fibrovascular strands. Psammomatous meningioma has psammoma bodies among the proliferating meningoepithelial cells. The prognosis for life is good in adults, although the tumor may be more aggressive in children, in whom 25% occurs. They are more common in neurofibromatosis type 2. The diagnosis is from the symptoms, which is a gradual visual impairment in one eye. The transient obscuration of vision may occur. On examination, there is a classic triad of signs called Hoyt-Spencer triad. The progressive visual loss, optic atrophy, opticociliary shunt vessels are the three signs in one individual is actually uncommon. The usual sequence of involvement is the opposite of that seen in tumors that develop outside the dural sheath. Optic nerve dysfunction and chronic disc swelling followed by atrophy. Opticociliary collaterals 30%, these regress as optic atrophy supervenes. Restrictive motility defects, particularly in upgaze and proptosis. Here you can see that there is an optic disc swelling. It is atrophy here in long-standing cases. You can see an optic disc swelling with the collaterals on it. Here you can also see the collaterals there. And these are the different histological appearances. This is Samoma bodies here. And here you can see this one. There is proptosis and also ocular motility disturbance in this case. And here you can also see there the tumor in the orbit along the optic nerve. Here also you can see the tumor along the optic nerve. MRI is the investigation of choice. CT shows thickening and calcification of the optic nerve. Ultrasonography, especially coronal, may be useful. Treatment is observation in case of a middle-aged patient with a slowly growing tumor. Excision is required for an aggressive tumor, particularly if the eye is blind or there is a risk of intracranial extension. Attempts at optic nerve sparing surgery commonly fail but may be considered on a case basis. Fractionated stereotactic radiotherapy may be appropriate for vision sparing or adjunctive treatment after surgery. Isolated localized neurofibroma is less common than the plexiform neurofibroma. About 10% of the patients have neurofibromatosis 1. It presents in third or fourth decades with insidious, mildly painful proptosis, usually not associated with visual impairment or ocular motility dysfunction. The excision is commonly straightforward because the tumor is well circumscribed and relatively avascular. The plexiform neurofibroma is the most common peripheral neural tumor of the orbit. It occurs almost exclusively in association with neurofibromatosis 1. It presents in early childhood. There is periorbital swelling. There is mechanical ptosis with a characteristic S-shaped deformity of the eyelids, diffuse involvement of the orbit with disfiguring hypertrophy of the periocular tissues may occur. On palpation, the involved tissues are said to resemble a bag of worms. Malignant change can occur and should be suspected if there is a rapid change. Radiotherapy may promote this malignant change. The treatment is often unsatisfactory and complete surgical removal is extremely difficult. Orbital surgery should be avoided when possible because of the intricate relationship between the tumor and the important structures. Here you can see this one. This is disfiguring. On this side, you can see the plexiform neurofibroma of the lids and also of the face and neck. And here you can see this one is so much disfiguring over there. This is an S-shaped deformity of the plexiform neurofibroma in the upper lid. The orbital invasions is from the adjacent structures like sinus tumors, the maxillary carcinoma, most common sinus tumor to invade the orbit. The ophthalmic examination shows an upward dystopia, diplopia, and epiphora. Other symptoms are facial pain, swelling, and epistaxis. And here you can see the swelling of the cheek with an upward dystopia and the swelling of the lower and the upper lids. Ethmoidal carcinoma causes lateral dystopia. Nasopharyngeal carcinoma spreads to the orbit through the inferior orbital fissure. Proptosis is late finding. The bony invasions, the intracranial meningioma arises from the sphenoid ridge, may invade orbit via direct spread and cause proptosis. Now here you can see this one, a maxillary tumor from the maxilla. Maxillary tumor is causing destruction of the floor of the orbit and invasion of the orbit. Fibrous dysplasia is a disorder in which fibrous tissue develops, usually in childhood or early adulthood. Presentation shows facial asymmetry, proptosis, and visual loss. Most orbital disease is due to the monostatic form. Monostotic form. The polyostotic disease is associated with endocrine disorders and cutaneous pigmentation. McCune-Albright syndrome. Orbital invasions from the eyelid, conjunctiva, and intraocular tumors. The eyelid malignancy, basal cell carcinoma, squamous cell carcinoma, or sebaceous gland carcinoma can also invade the orbit, or the conjunctival tumors like melanoma and squamous cell carcinoma can also invade the orbit. From intraocular tumors like choroidal melanoma and retinoblastoma can also invade the orbit. The orbital metastasis comprises 6% of the orbital tumors. In children, the primary lesion most frequently are neuroblastoma and Ewing's sarcoma. In adults, primary tumor is usually breast carcinoma or lung carcinoma. Orbital metastasis may be initial manifestation of the lung, GI, prostate, and renal cell carcinoma. Neuroblastoma is one of the most common childhood malignancies. It arises from the neural crest derived tissue of sympathetic nervous system, most commonly in the abdomen. Presentation is usually in early childhood. In almost half of all cases, the tumor is disseminated at diagnosis when it carries a very poor prognosis. Orbital metastasis may be bilateral and typically present with the abrupt onset of proptosis accompanied by a superior orbital mass and lid ecchymosis. Now here you can see the tumor involving the orbit, and here you can see bilateral invasion of the tumor, bilateral, the orbits are involved in here with a bluish discoloration of the lids. Myeloid sarcoma. The myeloid sarcoma, granulocytic sarcoma, is a solid tumor composed of malignant cells of the myeloid region. Because the tumor may exhibit a characteristic green color, it was formerly referred to as chloroma. Myeloid sarcoma may occur as a manifestation of the established myeloid leukemia, or it may precede the disease. It presents as orbital involvement which occurs at about age of 7 years with the rapid onset of proptosis, sometimes bilateral, and can be associated with ecchymosis and lid edema. When orbital involvement precedes systemic leukemia, the diagnosis may be difficult. Langerhans cell histiocytosis is a rare group of disorders due to the clonal proliferations of histiocytes. The presentation ranges from the localized disease, usually with bone destruction, called eosinophilic granuloma, or it may be a multifocal bone involvement, or it may be a fulminant systemic disease. Soft tissues are less commonly involved, but cutaneous and visceral lesions may occur. Orbital involvement consists of the unilateral or bilateral osteolytic lesions and soft tissue involvement, typically in the supratemporal quadrant. Patients with solitary lesions tend to have a more benign course and respond well to the treatment with local curettage and intralesional steroid injection or radiotherapy. Systemic disease has a worse prognosis. This patient, you can see the proptosis and dystopia here with the involvement of the superior orbit. The signs of the disease is dystopia or proptosis, infiltration of the orbital tissues characterized by ptosis, diplopia, indurated periorbital skin, and a firm orbit resistant to the manual retropulsion of the globe. In ophthalmos may occur with serous tumors, chronic inflammation may cause like an orbital cellulitis type of symptoms, and cranial nerve involvement may result into the ocular motility disturbances. Investigations are CT scan and MRI typically shows non-encapsulated mass. The fine needle aspiration biopsy for histological confirmation may be required. Systemic examination in search for a primary tumor must be performed by specialist. The treatment aims at preservation of the vision and pain relief. Radiotherapy is mainstay for local treatment. Surgical excision of the focus is occasionally carried out. Orbital excenteration is only performed if other modalities fail to control the pain and symptoms. Thank you very much.